So again, thank you for the intro. I've been looking forward to chatting with you all tonight, and thanks for making time. I think I wanted to focus on the topic of equine neurologic disease, especially as it relates to ataxia, which we'll talk a little bit about, because it's something we see pretty commonly at the university. Um, it's a performance limiting clinical sign that presents, and I think it can be a bit of a mystery. So I'm hoping to demystify a little bit tonight. So let's jump right in. So what I wanted to start with is a quick overview of the anatomy of the neurologic system in the horse. So, and this isn't just specific to the horse, I should say. This is for any species that has a brain and a spinal cord. So we divide the nervous system into three branches. So the central nervous system, shown here in red, includes the brain, and the brain has kind of three big parts. So it's got the cerebrum, the cerebellum, and the brainstem, and then the spinal cord. So brain and spinal cord are the central nervous system. Um, then we have in orange in this diagram, that would be the peripheral nervous system. So everything else, all the other nerves, your radial nerve, your ulnar nerve, the nerves that innervate your diaphragm, all of those are considered peripheral nerves. They all interface with the central nervous system to some degree or another, but they're kind of in the periphery. That's how they get that name. And the third kind of branch of the nervous system that it's kind of not shown here because it's more invisible, it's called the autonomic nervous system. And these nerves are related to all of the functions that you don't think about in your body. They are responsible for, the way your heart rate changes or your respiratory rate changes when you're excited, the way your intestinal tract contracts. So that's the autonomic nervous system. So those are the three branches. Um, and then I usually talk about information. When we talk about neurologic disease, we have to also talk about how does information travel from the brain to the rest of the body. And I like to think of it as a river. So the head of the river is up at the brain. So if you're going to have a conscious movement of your arm, that originates in your brain, and then that information flows all the way downstream like a river. The first stop is the neck, then we go over the back, then we get to the back, over the rump, and finally kind of the pelvis and thereafter. So if we think of it as a river, that's going to help us to understand when something goes wrong with the flow of information. So we're going to come back to this graphic in just a few slides here. So I think that's all you need to know about the anatomy of the nervous system. So let's talk about the definition of ataxia. So ataxia is just a description of movement. So it's a neurologic condition that affects coordination and balance. And any species can have ataxia. Humans can have it, dogs can have it, and horses. And ataxia results in varying degrees of uncoordinated movements, difficulty walking, and loss of balance. And those can be anywhere from very subtle signs to a horse that is struggling to walk and or can't even stand. So there is actually a 5-point scale to grade ataxia in horses. So I wanted to just share this with you briefly. So a grade of 0 is a totally normal horse. There's no trouble walking, very coordinated. And a grade of 5 is a horse that is unable to stand. And then we've got these degrees in between. So a grade 1 this is a horse that has some very subtle neurologic changes or deficits, as I'll call them. And you really have to put the horse in through special movements in order to elicit these changes. If you just looked at the horse walking up and down the barn aisle, you wouldn't notice anything was wrong. A grade 2 is there are some mild changes or deficits, and you can see these at all times. So if the horse is walking on a straightaway or turning, or they are, to a trained eye, you can see these at all gaits. Grade 3 is what we call moderate deficits at all times and at all gaits. So not just a walk, but also a trot or vice versa. And these are obvious enough that we say even lay people, people that aren't used to looking at neurologic disease in horses, will be able to see there's something not quite right about this horse's gait. And then the grade 4 is basically a horse that's at risk of falling over. So this is a horse that's tripping, stumbling, looks very unstable on its feet, but isn't yet down. So that's the 5-point scale. So ataxia there are really three buckets that can cause ataxia in a horse. One would be something wrong in the brain itself, and notably the cerebellum, which is that kind of bulgy part of the brain at the back, is particularly involved with balance and coordination. So we could have a cerebellar issue. Next would be if there's something wrong with the inner ear. So I don't know if any of you suffer from, vertigo, or if you've had a really terrible middle to inner ear infection. There are little hairs, projections in the inner ear that help you sense where you are in space. And if you have inflammation in there, we can develop ataxia. And then the third bucket is by far and away the most common cause of ataxia in horses, and that would be something wrong with the spinal cord. So either an infectious disease or trauma or some sort of dysfunction of the spinal cord. And that's where I'm going to focus our attention this evening. So if we return back to our graphic of how information travels, so if it's a river and info is flowing downstream from the brain to the tail, if there's an interruption, so if there was damage to the spinal cord, let's say it's in the middle of the back. So let's say our river becomes clogged up, a beaver's making a dam, the river's clogged, and thus nothing can get past it. So what that would mean is if information is flowing from the brain, probably all of the information is normal in the neck and probably the forelimbs as well. So those front legs are getting the information they need. And so this is a horse that in the front end is going to look pretty normal. However, you can see that the problem is in the middle of the back, so information isn't getting to those back legs. So in this case, if that was the only location, we'd have a horse normal in the front, abnormal in the back. In contrast, if we had a problem in the neck, the cervical spine, what we've got now is information that's not getting to either the front legs or the hind legs. So this is a horse that's going to have kind of deficits or abnormalities in all four limbs. So this will be important when we talk about our neurologic exam in a few minutes, because we really need to know where the problem is, because that helps us narrow down our list of what could be causing it. So, all right, so I wanted to list out kind of the most common causes of spinal ataxia. So, uncoordinated gait related to the spinal cord. And I've left out any diseases that kind of also can result in brain signs. So by that I mean, for example, West Nile virus. West Nile virus can cause ataxia. It certainly would fall in this category, but it doesn't usually occur in isolation without other signs. So these West Nile horses usually have changes in their behavior, their mentation. So for the most part, with a few exceptions, the diseases I'll talk about are an otherwise bright, happy horse, but that it has a wobbly gait. So here's the list, my kind of list of top causes of spinal ataxia. So they all have long names, of course, and they have some acronyms. The first would be cervical vertebral stenotic myelopathy or compressive myelopathy. It's abbreviated CVSM or CVCM, and it's known kind of colloquially as wobblers. So this is wobbler syndrome. We're going to talk more about this one and each of these. Next would be equine protozoal myeloencephalitis, also known as EPM, which a lot of us are very familiar with. Equine herpes virus. So there are multiple types of herpes viruses out there. It's herpes virus 1 in horses that can lead to a syndrome called myeloencephalopathy. So herpes can cause respiratory disease or abortions, but a subset will also dispose a horse to neurologic disease. The next bucket is two diseases that are very similar, equine neuroaxonal dystrophy or equine degenerative myeloencephalopathy. These both have underlying genetic and vitamin E deficiency causes, and I'll talk a little bit about that. And I would say from here, things get a lot less common. So intervertebral disc disease, so I have a bad back, I've had herniated discs in my life. That can happen in horses, but it's very uncommon, as is disease of the disc space or infection of the disc space. Cancer can affect the spinal cord in horses. Thankfully, this is quite rare. Next very rare is neuroborreliosis. So this is actually a neurologic disease related to Lyme infection. So infection with Borrelia burgdorferi is the bacteria that causes Lyme. I could spend hours lecturing you about Lyme disease and get on my soapbox about it, but I'm not going to. Needless to say, this is a very, very rare disease. And lastly would be trauma. So spinal cord trauma could result in ataxia. So which of these is most common? Well, fortunately or unfortunately, there isn't a lot in the literature that tells us what's most common. These are the 3 studies that I could find going back to the 70s. So in 78, there were 81 horses studied at Cornell. And of those, EPM was the leading cause of ataxia, followed by the vitamin E deficient disease, EDM, and then Wobbler's disease. And the others are going to be variations of that. So 19 ataxic horses in Canada were examined in 1989. Wobbler's disease led there at 58%. EDM was a distant second, with EPM being only 10%. And then the most recent study I could find is a big one, 316 horses in California. And of those, Wobblers was number 1. Unfortunately, the next big bucket was no diagnosis, which sometimes happens. And the third was EDM. So I've got a visual representation. This is a graph from that paper. So in this, the Wobbler's disease is in green. The purple and pinkish is an ENAT EDM. That's our vitamin E/genetic disease. Trauma is in dark blue, cancer is in light blue, and then the gray is no diagnosis. And so you can see an increasing trend. Hopefully you can see that the pink purple is increasing, and there are some reasons for this that we can talk if we have more time, but this is a nice representation of what's out there, I think. So what I'd like to do is just share a slide or 2 on each of these diseases before we go into how do we diagnose the disease. So let's start with Wobbler's disease, so CVSM. So the definition is when there's a narrowing of the cervical vertebral canal, so basically the pathway for the spinal cord, and compression of the spinal cord, often in combination with either a malalignment of 2 bones in the neck or a malformation. So we can have either kind of the bones don't line up well, or they didn't grow correctly in the first place. This disease in general has 2 facets. There's a genetic predisposition, so certainly this can be heritable and passed from generation to generation, but there are also environmental factors that have to be present. And we're still learning. Every day we're learning about this disease. There are 2 types of CVSM. The first one is kind of more that developmental facet. So it's mostly young horses, especially thoroughbreds, and it's multifactorial, meaning there are a lot of things that have to align in order for a horse to develop CVSM. So some of those, we know there are gender predispositions, genetics, like I mentioned, so this can be passed from parents to offspring. Diet, rate of growth, trauma, all of those things sort of play together to result in this disease. Type 2 is actually in older horses, and when this happens is there are the articular process. That's where 2 bones in the neck articulate or join together. There's a joint, and just like any joint, we can get arthritis at that articulation, that meeting of those 2 bones. And if you get so much arthritis and there's bony proliferation, that can actually change the shape of the vertebral canal and put pressure on the spinal cord. So there's sort of 2 big categories of this disease. It is important to note that as horses age, especially, it's normal if you were to take x-rays to see some bony abnormalities of the bones of the neck. That's okay. Just because that's there, it doesn't necessarily mean that they have spinal cord compression or will ever go on to develop signs. So a little bit more about this disease in general. So we know that thoroughbreds, warm bloods, and Tennessee walkers have been shown to be more likely to develop CVSM than, say, quarter horses, Arabians, and standard breds. Males tend to be more likely to be affected than females. The clinical signs for the type 1, especially, what we often see is hind limbs more affected than forelimbs. So we see that wobbly gait, that incoordination. Spasticity, what that means is sort of exaggerated movements of the legs. It's the horse, sometimes they look like they're marching or they're slapping their feet down. These signs in the type 1 with younger horses typically are symmetrical, so both left and right hind limb will look about the same. With type 2, as you can imagine, the arthritis can be worse on one side than the other of the neck. And so we can have asymmetry. So perhaps the left side is worse than the right, or vice versa. The history, oftentimes the ataxia will have these periods where they worsen, and then they'll kind of plateau and stabilize and be fine. They'll be at that level for a while, and then maybe something will happen and they'll worsen a little bit and plateau. So it's sort of this progressive, sort of insidious onset. These horses should not have a fever. So if a horse has a fever, I would say we should put this very low on the list. And then how do we diagnose this? So we can start with just regular x-rays. So plain radiography, by that I just mean a regular x-ray of the neck bones. What I mean here is static compression only. So there are two types of ways the spinal cord can be squished or compressed. The first is one is static compression, meaning that compression is there all the time, no matter what position the horse puts their head in, whether the head's up or flexed, it doesn't matter. There's compression there all the time. The other type is dynamic compression, where the spinal cord is only squished or compressed when the horse has its head in specific positions. So perhaps it's a dressage horse where we only notice signs when it's really collected and it's really kind of got its head tucked very close to its chest. That's dynamic compression. So I'll say that plain x-rays can detect static compression. So if that compression's there all the time, there's a fair chance we'll catch it on a plain x-ray. However, if we need to put the head in certain positions, x-rays aren't going to be good at that. So then we need to consider things like computed tomography or CT or myelography, which we're going to talk more about in a few minutes. So myelography, if there's a dynamic compression, that's really which direction we need to go to confirm that diagnosis. And like I said, I've got some pictures and I'll explain this technique a little bit more. So that's kind of CVSM or Wobbler's disease in a very small nutshell. So let's move on and briefly talk about EPM, equine protozoal myeloencephalitis. This is one that a lot of people know about. This is a spinal cord disease, or I should say a neurologic disease, that results from a protozoa that infects the horse and then migrates through the central nervous system, so either the spinal cord or the brain, wreaking havoc as this thing is migrating. There are two different protozoa in this country. One is Sarcocystis and the other is Neospora. Sarcocystis has been studied the most, has been known of the longest as compared to Neospora, but there are two different types. This can affect any breed, any age, any sex. There are some risk factors. People have studied EPM extensively. There are some things we know that can make a horse more susceptible to infection by the protozoa. So things like heavy exercise, competition, high intensity training, transportation, immune suppression, and all of those together, right? When we have a horse that's traveling a lot, stressed, that all of those things result in suppression of the immune system. So definitely immune suppression is there. Old age is a risk factor, but the middle-aged horses are more commonly infected when people look at them in studies. And I think that's because that's the demographic that's out traveling, they're in the prime of their life. So there's more opportunity for exercise, training, transport, and stress. Clinical signs of EPM. So EPM is the great, I'll say pretender. That's not quite the right word I'm looking for, but it can look like anything. So it can affect any part of the central nervous system. It can also affect peripheral nerves, so that peripheral nervous system. So it could look like just about anything. I will say that in most EPM cases, the spinal cord is typically affected. So we should see ataxia. because the protozoa don't migrate in an orderly fashion, it's typical for one side to be more affected than the other, because again, they're not marching in a nice orderly way down the spinal cord. And then we can see some atrophy. So that is muscle wasting, muscle loss, because the muscles that those nerves innervate suffer the consequences of having nerve damage. So those are the three, they call those the 3 A's of EPM. So those are the kind of classic 3 signs. But these protozoa can also migrate through the brain and the brainstem. And in those cases, we would see cranial nerve abnormalities. I'll talk a little bit more about those. You might see lethargy. You might see like a very dull mentation. Some of these horses have trouble swallowing. You might see changes to the function of the face. So EPM can look like anything. Again, these horses should not be febrile, or they shouldn't have a fever. And really, it's not a painful process, so we shouldn't really see pain associated with EPM. So if you see those things, or if your veterinarian finds a fever, I think I would still put EPM pretty low on the list. Diagnosing EPM is more challenging than it initially seems on the surface. So we need a combination of 3 things. We need clinical signs that fit the picture. We need to rule out all the other things that it could be. And then we need to do testing, immunologic testing. So we're going to measure antibodies that the body has produced. And I want to talk, I have one slide about this. I don't want to get too into the weeds about diagnostics, but this is one of my soapbox items as well, because we have a problem in this country diagnosing EPM, because the reason is the protozoa is everywhere. So Sarcocystis can be found throughout the country, and therefore horses are exposed to it a lot. So these numbers, up to 89% of some horse populations that have been sampled have antibodies against Sarcocystis. But just because a horse is exposed to this protozoa doesn't mean they're infected. So the majority of horses that are exposed mount a proper immune response and their body fights it off. They'll still have antibodies because their immune system saw that and it did the right thing. It made the antibodies, but that does not mean that they are infected. So just the fact that a horse has produced antibodies to Sarcocystis means pretty much nothing. Neospora, on the other hand, that's our less common protozoa. It's lower prevalence. So anywhere from very low, like 3% of the population, to 34%, depending on where you are in the country. So actually, in those cases, finding antibodies in the blood of a horse may be a little more useful. Still not a slam dunk. So here's one of my take homes for you. So a blood test for EPM is neither sensitive or specific. And what that means is you can't trust a positive or a negative test. So a lot of folks and veterinarians, I'll take the blame, we used to use the blood test as a screening tool. So what we would say is, okay, well, we know that lots of horses have been exposed to EPM. So if we get a positive, that maybe doesn't mean a whole lot. But if we get a negative, that probably means they weren't exposed. And actually, what we're finding now is that's not true. So there are horses that have passed away that have gone on to have testing after they were gone and have been negative on blood for EPM, but they've found the actual protozoa in the central nervous system. So really, we can't trust blood results either way. So one of my big takeaways for you is blood testing for EPM is not really a good use of time or money. What we have to do is actually collect cerebrospinal fluid, which I'll talk about, and compare it to blood. So I think I've got a slide about that a little bit later, but okay. You suffered through some of my pontificating. All right, next up on the list was herpes virus 1. We talked about this as being one of many different types of herpes viruses, and EHV1 can lead to a syndrome called myeloencephalopathy. So it's not to say that all horses that get EHV1 will go on to have EHM, but some of them will, some subset will, and we don't really understand why some horses go on to develop the neurologic form and some don't. Also, concerningly, although we can vaccinate for EHV1, the vaccine does not protect against myeloencephalopathy. So unfortunately, we can't prevent that at this time. Herpes in any species is never cured. It waxes and wanes. So what it will do is initially it'll spread, it's highly contagious and it spreads through the respiratory tract, especially when horses are stressed. So shows, transport, travel, those are great times for a horse to shed herpes virus. And then what happens is they don't rid themselves of the herpes, but it becomes latent or dormant. So it sort of goes into hiding. And then later, during periods of stress, it can rear its ugly head again and the horse can shed again. So up to 80% of horses that are infected with herpes virus 1 an initial time will experience these latent infections. And they don't always show signs of it. Just because a horse is shedding, they may not actually, most I would say, aren't showing signs when they're shedding herpes virus, but it does pose a risk for other horses. So clinical signs of herpes virus. This one can be either symmetrical or asymmetrical. In general, the hind legs are more affected than the front legs. And then some other hallmark things that often go along with EHV1 and EHM, I should say. We get things like bladder dysfunction. So mares and geldings will, or stallions, I guess they'll dribble urine. You might notice that the tail tone is very decreased. They're not defecating as well because they can't actually constrict and defecate normally. And these horses are weak, so they spend more time laying down in recumbency. I have that brain signs are uncommon. I guess that's true. I think it depends on if the horse is just shedding because they're in a time of stress or if they were just first infected. But I would say most of these horses they're quiet, but probably otherwise normal. And then some have a fever and some don't. Diagnosis actually is pretty easy. So we can do that we do both a nasal swab and a blood sample, and we can detect the virus that way. So this is one where we can pretty quickly get a diagnosis for that. You can also detect the virus in spinal fluid. If you were already collecting spinal fluid for another reason, you could certainly test for that, but this is one where we've got a good diagnostic. All right, moving on to the acronyms abound. So I'm going to call them ENAD and EDM. These are two very similar degenerative diseases of either the brainstem or the brainstem and the spinal cord. So basically, ENAD is a milder form of EDM. EDM is a more diffuse, severe form of ENAD. So it's a spectrum. And there are two things that we need typically to develop ENAD or EDM in a horse. The first is vitamin E deficiency, especially there's a critical window. So the last trimester of pregnancy in a pregnant mare, all the way out to the first 2 years of a foal's life. Any vitamin E deficiency for a prolonged period of time in that magic window is going to set up a risk for these diseases. And then there are genetic risk factors as well. So we absolutely can see families of horses affected by ENAD and EDM. To some degree, the genetic risk can be overcome by supplementing with vitamin E, but it has been reported in, I can't even count anymore how many different breeds, and there doesn't seem to be a gender predilection, so both males and females. Clinical signs of these ones are not always, but usually symmetrical. So that's a bit different than what we've seen so far. Funnily enough, especially warm bloods, what we've noticed over the last 10 years or so is that behavior changes is one of the most commonly reported signs by owners. They notice that their horse isn't the same horse anymore. So that could look like a horse that used to be a very calm, quiet guy suddenly spooks or becomes aggressive. Maybe, or opposite, the horse used to be very spooky and high strung and now it's very dull. People report that their horses that they don't recognize them anymore, that they'll go out to the barn and the horse used to nicker at them every day and now suddenly it's like you're a stranger. So behavior changes are often, I think, one of the first things that owners see. In warm bloods, it can also have impact on the back of the eye, so the retina. So some of these horses will have vision changes, and it's possible that that's contributing to the behavior changes as well. Problematically, there is not an ante-mortem, meaning in-life test for ENAD and EDM at this time. There are several very talented groups of people out there, notably at UC Davis and at UPenn, working very hard to develop a test for this disease. We can do things like measure vitamin E in the blood, we can do muscle biopsies, but right now there isn't actually an in-life test for ENAD or EDM. Moving on, trauma. So this is an image of a horse I saw years ago. Was actually in a race and finished the race, and then suddenly was down in the barn and couldn't stand. And turns out this horse actually fractured one of the bones of the thoracic spinal cord. So like we talked about with the flow of information, the way a trauma presents itself is going to depend on what level of the spinal cord is affected. So in this horse, it was in the middle of the back, and so unfortunately he wasn't able to rise in the hind limbs, even with help. If a horse fractures its neck, that's going to be a horse that can't use any of its legs. So we try to diagnose trauma with x-rays, CT. I'll share a little bit. We're limited with CT based on the size of the animal. Same with MRI, even more so. We really can't fit anything in an MRI unless it's very small. Sometimes spinal fluid can help us diagnose trauma. Sometimes we'll see evidence of bleeding if there was trauma to the spinal cord, but these can be a little challenging. You'd think, well, this is trauma. How hard could it be? But sometimes it can be tough to prove this. Moving even further into the very uncommon things, wrapping up with our causes here. Intervertebral disc disease. So this is a very well described problem in dogs and humans. But I think based on just because of the size of the horse and our limitations with things like CT and MRI, it's really a rare diagnosis in horses. Really, there's just a handful of reports of individual cases of intervertebral disc disease out there. My suspicion is that it's actually much more common than we know, but because we don't have good tests available, we can't see that part of the horse. I think it goes underdiagnosed. But these horses will have ataxia and potentially weakness in 2 to 4 legs, depending on where the problem is. Same thing with trauma. We can try to do x-rays or CT, but this is very challenging to prove in life, unfortunately. Almost done, I promise, with the causes. So discospondylitis, another very rare disease. This would be where we have not just the disc is affected, but also the bones of the vertebrae on either side. So it's the bones and the disc, and it can be either inflammatory or infectious. We often see this in cervical or thoracic vertebrae. This is very uncommon in adult horses. And when we do see it, it's either from like a trauma, so say something like a penetration of something like a stick or a fence post or something. And then very rarely in foals, if they're septic, basically, if they have bacteria in their bloodstream, sometimes it will affect the bones of the spinal canal or spinal column, excuse me. These horses should be painful, so stiff gait, really reluctant to bend their heads and necks. They often will have a fever. They're not going to want to eat, and they will be ataxic. So these ones look definitely more sick than the others that we've described. Diagnosing it, we can try to grow the bacteria, but as you can imagine, say this is in the back of a horse, there's a lot of horse in between a needle that you need to collect the sample and the site of infection. So this can be really challenging, both to diagnose and to treat. Getting closer to the end here, neoplasia, which is cancer. This is just a list of some of the many types of cancers that can affect the spinal cord. Fortunately, very rare. And sometimes they're benign, meaning they don't metastasize. They're not a big deal. Like, for example, this bottom right, that's a little fibroma. So this is just a little mass of basically fibrous tissue. It's not going to go anywhere. It's not going to cause, any changes anywhere else. But the spinal cord is very small. So if this cord, this canal isn't very forgiving. So this little guy was putting a large amount of pressure on the spinal cord here. This top picture, this is melanoma, so this was in a gray horse. So we know that our gray friends, unfortunately, get melanomas externally. We see them on the tail head or, around the sheath or what have you. But that they can have internal melanoma as well. And same thing here. So it's just compressing the spinal cord. So we can try to evaluate the spinal fluid of these horses to get an answer, but I hope you see the theme that's emerging is that diagnosing neurologic disease can be, especially spinal cord disease in horses, can be a real challenge. So the last cause I want to speak very briefly about, because otherwise you'll never hear me stop, but neuroborreliosis is the neurologic syndrome associated with Lyme disease. It's a very rarely reported syndrome. And the seroprevalence, meaning seroprevalence is what percent of the population of horses has antibodies to this. It's variable. So obviously, like New England, very dense population of the ticks that carry Borrelia. So almost all the horses there have antibodies to Lyme disease, but that does not mean they have Lyme disease. So the rate of the neurologic syndrome is very low. I have seen 2 of these in my entire career. So this is a very rare disease, thankfully. Clinical signs, interesting, what we usually see first is it almost looks like lameness. So it does affect the central nervous system, but we can also see peripheral nerves. So, one leg that is very painful and a horse, doesn't want to bear weight or put weight there. We can see it affect, as it progresses, we'll see behavior changes and maybe the nerves that innervate the face are abnormal. And then eventually these horses will lose weight and have muscle wasting. Diagnosis, just as it is for any other type of Lyme disease in any other species, it is challenging. So blood tests for Lyme disease, useless. Sometimes we can test the spinal fluid, but this is a doozy to diagnose. And I think my colleague, Dr. Christy Ward, hopefully within the next, semester next year, she's going to present on Lyme disease. So whew, that was a whirlwind tour of the ideas or the things that come to mind when I think about spinal cord disease in a horse. So I wanted to just briefly touch on how we work these up. And what it starts with is a complete neurologic exam. So I'm going to focus a lot on the neuro exam because that's the bread and butter. And then from there, the things that a veterinarian might recommend if your horse has ataxia would be x-rays, potentially a CT, depending on what's available, spinal fluid analysis, and measuring vitamin E. And then I've got the other 4 become more advanced. These are kind of advanced procedures that we might sometimes recommend if we haven't gotten the answer from the beginning. So let's start with the neurologic exam. So this ideally is performed by either a board-certified internal medicine specialist, or it can be a practitioner, but it really should be someone who has performed a lot of these. It's an art to detecting neurologic disease, and I will say that even with years of training, it is a subjective thing to grade neurologic findings. So you definitely want to rely on a practitioner, somebody that has done a lot of neuro exams, because they can be tricky. What I teach the students is we have 3 questions we have to answer today when we start a neurologic exam. The first is the horse neurologic? Yes or no? From there is, which limbs are affected? So if you recall back to our graphic, once we know which limbs are affected, we can decide where the problem is. So for example, in a horse where the forelimbs are normal and the hind limbs are abnormal, we know that the flow of info must be normal up through the neck and the front limbs. So we know the problem either has to be the back or further. Versus if a horse is abnormal on all 4 legs, the problem has to be the neck, because that's the only way the information stops getting to all 4 legs. So that's the second question, which limbs are affected? And then lastly, what grade is it? So then we'll go through and talk about the 5 grades I already introduced. So those are the goals. And then there are 3 parts of the neurologic exam. So the first is the cranial nerve exam. So any mammal has cranial nerves. There are 12 of them, and they are paired. So this is a human graphic, but they're the same. So there are 12 nerves that basically innervate and are responsible for everything on the head, and also things like swallowing. We have the vagus nerve, which can help with digestion. So these are critical nerves, but they originate on the brainstem, and we test all of those kind of individually first. Next would be the static exam. So this is where the horse is standing still, and I'm going to do things like pull on his or her tail to see how strongly they pull against me. I'm going to place their feet in abnormal spots and see how they respond. And then we move on to the dynamic exam. So this is a horse in motion. So I would say most of our exam is done at a walk. We will do some trotting. I don't usually need to see a neurologic horse canter. That's just not what I need. So most of this is done at the walk, but we have very specific things that we ask a horse to do to assess. So I don't want to go through all of these, but the static exam will be, we're going to look at muscle symmetry, tail tone. We're going to ask the horse to flex his head in multiple directions. We're going to put the limbs in different places. Cranial nerves. So what we'll do is we've got some reflexes of the eyes that we can look at. We're going to look for any asymmetry of the face. We're going to test the horse's ability to swallow and the tone of their tongue. And then the dynamic exam, here are some of the examples. So we're going to ask a horse to walk with their head elevated and up and down a hill. We're going to watch as it backs up and ask it to navigate a curb or some poles. So this is sort of the overview of what I do. So what I've got next is some videos of normal and abnormal neurologic exams. And so I'll start with normal. I'll say that the abnormal here, I know it's going to be distracting, but I put some like black bars up to sort of like keep the confidentiality of the patient. So I'm sorry if those black ones are disruptive. But so first one on the left, this is one of our teaching mares. So I'm asking her to turn her neck, and she should be able to bring that nose all the way back to her barrel, to her side. And notice that she's keeping her head very up and down. So she's not really, I'll call it cheating. So she's got her head right up and down. She's doing a nice job there. So we're going to ask them to go in both directions, left and right. And then we also want to make sure that they've got good range of motion all the way to the ground. And then I would also stand on something tall and ask her to put her head way up in the air. So I don't have an abnormal of this one, but because I couldn't block out the patient well enough. But what I should say, let me go back. So sometimes horses that are neurologic, what you'll see is instead of keeping their head up and down, they'll turn their head horizontally so that now they're sort of, their head's like parallel to the ground. I call that cheating. So either they'll cheat and not keep it up and down, or they won't be able to get back as far as I would like. So that's what an abnormal one of those would look like. This is placing. So we're going to ask a horse to put their legs, all four legs, in different positions. So first we're going to put it, either this one we're going to ask him to stand really way out there, and his body should sense that that's not where that leg goes, and he should correct it. So she had just, I know it's cut off at the beginning, but she had crossed his legs in the front. Here he is. So she just crossed him, and he says, nope, that doesn't go there. And he puts it right back. So this is very normal. I'll say that placing is one of the more subjective tests that we do, because a very willing horse will let you put his feet wherever you want. So whenever we're doing a neurologic exam, we're never going to hang our hat on one abnormal finding. It's going to be assessing all of it together as one big picture. So that's a normal placement. So here are some abnormal placements. So in this horse, this is called a abduction. So we've got the leg way out there, and he doesn't seem to know that that's not where it belongs. And so here, this is adduction. She's going to cross his leg, and he should really notice that his leg doesn't go there. So much for my box covering his head. Whoops. And here's another example over here. Let me just stop this guy. So she's going to bring the leg way out here and ask him to correct that. And he's just kind of leaving that leg out in space. And so she'll give him a little stimulation, and he goes, oh, okay, I guess that doesn't go there. So those are abnormal there. Here's a normal backing. So you probably don't think a lot about normal backing, but see how this horse is, for the most part, picking up his feet, especially the back feet, and placing them where they belong, not really dragging them. His hind end, his rump stays very straight and level, looks very comfortable here. that's how we expect a horse to back up. So here's some, again, sorry about the black bars, but here is a horse that's very resistant to backing. So you can see that he leaves these hind feet down for a long time, and he's sort of, hopefully at the end you can see he's just sort of dragging this back. Let's watch that again here. So especially towards the end, this left hind, you'll see it here, he just kind of like drags it. He's not really picking it up very well. And you can see him getting kind of camped under back here. So he's really struggling to back up. And then this horse, what you should watch is the rump. So this horse is gonna look pretty weak in the hind end as we ask it to back up. Gets really low to the ground, just looks like it's struggling. And I think we'll watch it again here. Almost steps on itself a few times there. This is just not a coordinated backing effort here. Next, what we'll do is ask them to walk with their head elevated. And what this test does is, so ataxia, horses, dogs, people, we can compensate for ataxia with vision. So we may not be able to feel where the ground is, you know, with our limbs when something's wrong, but we are visual most of the time and we can see it. But in a horse that is ataxic and you take away their ability to see the ground, sometimes this will get much worse. So the other way we could test this is to blindfold the horse. They don't tend to like that very much. So this is a horse who's very willing to walk. He even trots at the end. I don't really see, he looks just like he does with his head down, moving very well, happy horse. So here are some abnormalities. So in this first video, this horse is doing a couple of things. So the first is he's kind of marching in the front. So if you watch those feet, he just looks exaggerated and he's slapping his feet down and he looks like he's marching a little bit. And the second big thing to notice is he's pacing. So you can see that the left front and the left hind are moving at the same time, as are the right. That is not normal. So horses should alternate, right? So we should see kind of it should be a 4-beat gait, and they shouldn't move like this with half the body moving at a time. So that's an abnormal stance. This is that same horse coming from the front and his head's up. So what I hope you can see is more of that sort of like marching. He's sort of flipping his toes out. He's very wide in the front and he's pacing again. It's not as clear as from the side view, but this is very abnormal. All right, circling. So a normal circle, what we should see is our feet should always be moving. And so watch his hind feet. He's gonna cross his hind feet over very nicely. He never just plants one leg. Even his front legs are crossing over really nicely. He's not tripping. Looks pretty good there. So here is a horse that's just doesn't look coordinated. Sorry, I know it's just his feet, but that's all you need to see. So what I want you to notice is he gets sort of like, he's not crossing over here. He's sort of just shuffling side to side. He doesn't really know where to put those hind feet, especially. The fronts are doing okay. But back here, he's like, I don't know what I'm doing with these feet. And then this horse over here on the right, what I hope you can see is if you watch the outside leg, at times, he's just going to kind of, it's going to wing it. He's going to wing it out there a little bit, almost like he's sort of reaching for the ground. This one's a little more subtle, but he also isn't crossing over consistently. He does it sometimes, but it just doesn't look smooth, right? It just looks like maybe he doesn't quite know where his feet go. All right, let's see what we've got next. So here is a horse on soft ground. I often do this on soft ground too, and you'll just see the wheels come off on this show. So as we ask for tighter circles, there's no crossing over. This horse is actually going to plant a leg back here. Let's see, I can show you again. So if you watch, at one point, this left hind just gets planted in the dirt and just pivots around that. So that's very abnormal circling as well. So a thorough neurologic exam, critical. This is where we always start. We answer those 3 questions. Is the horse neurologic? Which limbs are affected and what grade is it? and that's going to dictate what tests we need to do next. So I would say that very frequently what we would do next is x-rays and spinal fluid collection. So looking at the spinal fluid under the microscope can help us narrow down some of those causes. We look for color changes. Sometimes you can see evidence of bleeding, so if there was a trauma. We're going to look at the cells that are present, and very rarely we can find cancer cells if there's a tumor near the spinal cord. Critically, in order to rule in or rule out EPM, we absolutely need CSF. So don't let anybody tell you otherwise. We need CSF as well as a blood sample. They have to go together in order to take EPM off a list. And then there are additional things we can test on a spinal fluid sample, such as Lyme disease, although that's a whole nother can of worms. I'm actually going to skip past this one. I want to talk about x-rays. So plain x-rays in a standing horse, especially the cervical x-rays, so the neck is what we're talking about here. We can detect fractures, malformations of the bones of the spinal cord. Like I said, a static compression from wobblers. If there's a luxation, so the actual bones aren't lined up the way they're supposed to, arthritis, and then potentially infection of the bones and the disc. These can be done in the field. So general practitioners, your regular veterinarian can take cervical x-rays in the field if they have x-ray equipment. I will say that sometimes the more powerful overhead units that are in a fixed hospital will offer a better quality image. But that said, if you've got somebody that knows what they're doing, they've taken neck x-rays before and they know how to interpret them, these can absolutely be done in the field. Here's an example of the difference in the quality. So the bottom right, this is the same horse. These two images are the same horse. And I hope what you can appreciate is we can see mostly what we need to see here. We can see the bones of the vertebrae. Everything looks good. But with the overhead unit, which is more powerful, you can see a lot more detail. So this is a more refined image. So once we have the x-rays, we do things like take measurements. So we're looking for evidence of narrowing of the canal. So the area between these small green bars, that's where the spinal cord lives. So there are lots of different formulas out there that we can use to decide, is it big enough? And then these are some very old photos, but you could see these are evidence of discospondylitis. So these black areas are where bone has just been eaten away by infection. So we can see a lot with x-rays of the neck. What we can't see a lot of is the back. So if the problem is anywhere, so there are 7 bones in the neck, 18 thoracic vertebrae, and 6 lumbar vertebrae. And really, we can only really see the first thoracic vertebrae and then from about here to here. And the reason is most horses are so dense, they have so much muscle and fat covering this. We just don't have machines that are powerful enough to see what we need to see. The images just are not as good. So we can see the cervical vertebrae quite well, pretty dicey to see anything. We can see the spines. So kissing spine is a disease, right, where we can see the very tips of the vertebrae. But what I'm talking about is down here where the spinal cord lives. That's a lot more challenging. So of course, I'm running out of time. I just want to touch on myelography really quickly and then I'll wrap up. But myelography is the definitive way to determine if a spinal cord is being compressed. So for Wobbler's disease, it does require a horse to be under anesthesia, but these can be very brief anesthesias. And what we do is, instead of just the plain films, we can actually put their neck in different positions to see if we have that dynamic compression we've talked about. We can do a myelogram with either x-rays or CT, and by we, I mean certain clinics. This is our clinic here. We're doing an x-ray myelogram. So what we do is we take out some spinal fluid, and then we actually inject some dye around the spinal cord, and then we take x-rays of the neck in different positions. So this is in that neutral position. This is now in an extended position, and then we compare those. And so what you get is this image where these bands of gray tissue, light gray tissue, that's the actual dye that we injected. And you can see it here. There's 2. There's on top of the cord and underneath. And what we would look is, do we see if this area has been compressed at all? So that's how we diagnose that. I have a lot more on CT and nuclear scintigraphy, but in the interest of time, I don't want to keep you long. So I'm gonna cut this off and stop sharing and go from there. I think I have a slide for questions, I'm happy to take any questions.
All
Sorry,
right.
sorry that I'm running
Yeah.
short.
Thank you. No, thank you, Dr. Barrell. Yeah, we can transition to questions now. Thanks for that wonderful presentation. That was wonderful. We do have a few questions. I'll combine the first one. Two people phrased it kind of a similar way, but I'll combine this one. Can a horse owner distinguish between symptoms for ataxia and symptoms associated with conditions like laminitis, foot pain, or white line disease?
That is an excellent question. And the answer is no. They are often mistaken for each other. So I will also say the other thing is subtle lameness and subtle neurologic disease look very similar and can be very, even for me at this stage in my career, been doing this a long time. I sometimes have to really struggle to say, is this horse lame or is it neurologic? So absolutely, I think especially laminitis, right? Those horses move very strangely, and that can absolutely look like neuro disease. Great question.
Great, thanks. Are there other diseases or comorbidities that occur because of an ataxia diagnosis? And can a treatment for one disease help the treatment of symptoms of a different disease?
Hmm. In general, I would say what we don't have time to talk about tonight is treatment and outcome. Um, Unfortunately, a lot of these diseases either don't have a good treatment or don't have a great outcome. So aside from EPM, which is quite treatable, herpes virus, which sometimes always resolves, the virus always is gone, but doesn't always, sometimes it leaves lasting effects. Um, and then potentially trauma that isn't catastrophic. I would say that those are the three that with time, rest, and supportive care, and with EPM, there's a treatment, an FDA approved product. The others don't always respond well, and they have different treatments. So
Right. Okay.
that's a hard one to answer succinctly. Sorry.
No, that makes sense. How frequent or intense should symptoms be in a horse before an owner should diagnose or
You cut out there, but I think you meant, I think you said before referring or before seeking opinion. Is that right?
Yep. How frequently or intense should symptoms be before seeking?
Um, I think the sooner they can be seen, the better. So for the things that are treatable, for example, EPM, we have a better outcome when we treat it early in the course of disease. So I would say if you notice that your horse is moving abnormally, I would have your veterinarian out to look at them and then go from there. And maybe you don't need all of the diagnostics we talked about, but a thorough neurologic exam is affordable and worthwhile. So I would say sooner rather than later.
Makes sense. Thank you.
Mhm.
This one for EPM,
Mhm.
are certain environments more likely to have a higher prevalence of?
So yes, um, we definitely see it more in things like New England, the northern central states. Um, the poor possum, sadly, is part of the life cycle of the protozoa. Possums are great for a lot of things, unfortunately not for EPM. So having possum feces basically a horse has to be exposed to possum feces in order to contract EPM. So trying to keep food stored tightly in places where the critters can't get to it, not leaving things like cat food out, and then cleaning up, feeding in hay bunks, things like that. So there are environmental things we can do to reduce a horse's risk of exposure, but there are geographical pockets in the country as well that see more EPM than others.
All right, we'll have time for one more here. Are you
Okay.
seeing any increased rates of ataxia in your clinical work?
I don't know about increased rates. I will say that ENAD and EDM, those vitamin E related diseases, we are seeing more and more of that. I'm diagnosing more and more of that, and it's being studied more. But I think it was always there, to be honest. I think it was, we didn't know that it was a thing. We didn't recognize it. It was maybe one of those that went undiagnosed. So I don't know that that necessarily is an increase in the incidence, but I think we're getting better at diagnosing it. Otherwise, I think neuro has been big my whole career. So yeah.